hope so. Your families are doing very well. And a warm welcome once again to this evening's program. I think we'll just give it a few minutes while we wait for the participants to join in. So this evening we've got Dr. Paul Fouche, and who will be our guest for the evening. But let's just wait a few minutes. Van der Berg introduces him to you. So we've about 300 and almost 70 participants joining in. So we'll just give it a few more. Welcome. Welcome on board, and thank you this evening for joining us. Just quickly ask, how has the lockdown been? How's level 1 treating you so far?
Sorry, Dr. Bickel, I didn't get you there. Are you speaking to me now, Dr. Van der Berg?
Yes, no, I'm speaking to you.
No.
How
lockdown
has been treating you?
Yeah, no, I mean, I'm sure for everybody it's much the same. It has been unknown times, especially starting out with the new practice and really want to get out there and see your patients, and especially with orthodontic treatment, your patients being in active treatment and having fixed appliances. So no, those can be tricky times, I tell you. So, but I'm sure, as with all the colleagues, everybody did as much as they could. I felt quite a solidarity among the colleagues to really have the best interests of the patients at heart. So it's definitely been challenging, but yeah, what can we do? We take it as it comes.
I saw a funny ad today with a patient wearing a mask, and it said that this is the best time to get orthodontic treatment done.
Oh, absolutely, absolutely. My adult patients they're loving it. They can hide their metal work underneath their masks, so they're really enjoying this mask time. So it's definitely favorable for orthodontic treatment, I must say.
I see. All right. So I think we've got about 415 participants that have joined. So I think for those who have just now, a very good evening, ladies and gentlemen. Welcome to this evening's webinar. Also, and Sada, and hope you're doing well. Hope the year is going fine. I hope that you had a very good oral health month, and now we're into October, and the year is going very fast. So, ladies and gentlemen, just a few announcements before we proceed. Should you have any questions or comments, please feel free to type it in the Q&A section. Just please avoid using the raise hand. Your CPD certificates this evening will be issued on the website, the SADA. And if you are not a member, you can always create a profile for yourself and access your CPD points via that platform. This evening's session qualifies you for 1 point. Also, would like to view this session on the YouTube channel, and just view it on the SADA YouTube channel, or even at a later should you to this webinar, you can visit the YouTube channel. I would just like to make an announcement also. There will be an evaluation poll at the end of the session. Ladies and gentlemen, I really encourage you to please fill in that poll. That gives us a better of how the session was and improve with our further sessions. Coming up for the month of October, we have some sessions. On the 8th of October, we have a SADA PPS partnership launch. You're welcome to register yourself for that. On the 13th of October, we have a SAS webinar by Prof. Ephraim. Then on the 20th, on the 27th of October, we have a SASPIO session by Dr. Fahim Bamji. So, ladies and gentlemen, I would just like to pass over to Dr. Johan van der Berg, who will now introduce our guest for the evening. Dr. van der Berg is an executive member at SASO. So, Dr. van der Berg, over to you.
Thank you, Dr. Bika. Good evening to all the listeners and the viewers. I'm a representative of SASO's EXCO. So SASO represents all the orthodontists in South Africa. We're a small community of about 150 people, orthodontists, and it's my pleasure to introduce our speaker tonight. But before I do that, I just want to thank SADA for the opportunity to be involved in this event tonight. SADA is our parental body, and we are all members of SADA. All the SASO members are both members of SADA and SASO. So welcome, Paul. So very nice to have you here. Thank you for availing yourself to come and teach tonight. So Paul is a good colleague of mine, and we've had much interaction since 2015, particularly during Paul's postgraduate studies at the University of Pretoria. So Paul finished, he's a top student, by the way, and he's done his pre-grad studies at University of Pretoria, finishing in 2007, top of his class with distinctions and multiple awards. He's completed his postgraduate diploma in 1 year with distinction also at University of Pretoria. He has completed research methodology, and he was a junior lecturer in orthodontics at the University of Limpopo in 2013 till 2014. Paul, he was accepted for his master's in orthodontics in 2015 at UP, and he completed his degree with distinction in 2018. Paul he's just opened his practice fairly recently in Kempton Park, and he also serves as a consultant at the University of Pretoria. So without wasting more precious time, I know, Paul, you've got a lot to say, and so I'll hand over to you. Thank you.
Thank you very much, Dr. van Baar. It's such a privilege to be able to talk to the colleagues this evening. I really want to thank SADA for the opportunity for really creating a stunning platform for us to engage. Me and Marilise, the co-host of this meeting, had a little bit of a joke about how my wife had to help me set up the Zoom meeting, because I'm not so, as a millennial, I'm supposed to be way more clued up with the technologies and how to use these things in the chat on the side, and it is so funky. And it's just another wonderful way to engage and really just talk to each other, to really get to a point where we can sit down and say, from our perspective, what does growth look like? What does managing our young patients look like? And hopefully from your guys to respond and how you see it, and maybe some revision this evening, and just share some thoughts. So without any delay, let me now do this fancy share screen thing where I now click here and then get to my slideshow. So let me just put this guy. Okay, so first things first. I want to, first, it feels so formal with this sort of background. It feels like I must have this news reading paper and say, welcome to the news at 7. So it feels like really strange to have this very formal background. I usually like a little bit more interaction or one-on-one, but these tough times call for us to meet electronically. So we're going to chat about our growing patients and when we should act. So often, I remember when I was in practice, a patient would come to you, the parents would want more information, they really look up to you, they want to have some information on you, there's something wrong with this child's bite, or can you have a look for me and give me more information? And then often you would steer away and say, no, wait for all the primary teeth to exfoliate, wait till all the permanent teeth are out, or the bite looks like this, but you were never really sure. So I think it's good for us to maybe just revise and check again. Let's go back to the basics. Let's start at the very beginning. So we're going to talk about our growing patients. So let's start with the most important thing is, Paul, why are we even listening to you today? So I've made this first slide so that I can just chat to you guys about whenever there's somebody introduced as a speaker, you think that, you know, what is the background and what is the history of this guy and how much maybe experience do they have? So I want you to take that mind filter and really walk with me this evening on what is it that maybe we can learn from it. So it's a very valid question, Paul, why are we listening to you today? Very valid question, and it should be asked. I think the answer is very simple. With specialist training, I simply had the opportunity to make the mistakes, and certainly many of them. So you often are overambitious and jump in, or you wait too long. But yeah, definitely made the mistakes. But I think most importantly is when you've made the mistake is to reflect. To reflect, sit back, see what can be learned from this situation, adjust. So I think orthodontic treatment, or not even orthodontic treatment, maybe dentistry in general, is like driving. Now I know a lot of people, sorry, I'm just going to sip on this water now and then, feel like, you know, everybody can drive, but I'm just a bit better. So it's like driving. You think you're really good at it, and if you're good at dentistry and you're enjoying it and you're enjoying treating your patients, but you don't see the outcomes that you often want to, then you must be able to stand back and reassess and adjust what you've done or your way of thinking, and then hopefully to get a point of correction where it's most efficient. So for this evening, I'm asking you, I'm a big fan of Andy Stanley. He's the pastor and founder of North Point Ministries in Atlanta. And he suggested that to be a leader, you have to be a student and not a critic. So it's easy to look at maybe cases that were completed or information mentioned and look back and be critical and like, no, that's not the way I would do it, or that is not right. Maybe open your mind a little bit. We all need to be students. And then you ask me, but why do we talk about being leaders? And I think we underestimate ourselves. I think we as dentists really underestimate ourselves. Our communities, our friends, our family, our peers, they really look up to us for leadership. When they ask you a simple question around the braai or anything, they really, I can see they listen to what you have to say. So never forget that you've got a very important leadership role in your community. So that being said, just a little bit background about myself. I live in Kempton Park, and believe it or not, from Google, this was the last aerial picture that I could find, the most decent one, and it looks way different. So yeah, an airplane is just passing right now, and we're so glad to hear them again. It means that people are traveling and the tourist industry is going to pick up as well. We've got Empress Palace, the gambling house is closed, and we've got big industries. And then sometimes we're in the news for not so positive things. In October 2019, Panellists Lesotho had to visit because we also like giving each other maybe a little bit of a brawl in the butt corner. So yes, that is Kempton Park for you. So yeah, me and my wife, we opened our practice, Fouché Orthodontics in Kempton Park. And in 2019, I think it was a big step of faith, and we are so grateful that we did it. And I always had this dream of just having a really nice place to work at. So I'm sure when you guys get up in the morning and you go to your practice, you just feel like I need to be here, and it must feel great. So yeah, we had lots of help on setting up the practice and making it comfortable and practical at the same time, and enjoyable, and really focusing on giving our patients a quality experience. And I'm sure those of you who are actually taking the trouble and time to view these webinars, you guys share that same passion, that you really want to just give your patients the best. And that's why you're listening to the information. So everybody in my age hopefully knows the sound of music. And Maria von Trapp would say, let's start at the very beginning, because it is a very good place to start. So when I actually went to the books and was like, okay, let's get a definition on what growth is, there wasn't a really like textbook, this guy said that in 1970, wherever. So let's go to Google. So Google said, what is the growth? The growth is the increase in size, widening, broadening, thickening. So it's basically just really something that's flourishing and thriving. And I was really in love with those words, you know, flourishing. If we can get that mandible to flourish at some stages, that would be fantastic. So yeah, it's not something complicated. It's not a complicated term maybe, but damn, it is intricate on how all these things come together, especially in the human face. So the human growth differential is just basically a statement saying that different tissue groups all contribute to the growth of the face, or growth of and influence of the human occlusion. So it's especially applicable to all of us to understand the concept of growth, the face, development of occlusion, and to understand that there are multiple tissue groups at play. We've got the neural tissue, so we've got, of course, the expanding brain, which is the calvaria, and then the cranial base, which all part of the neural group, the somatic, the body tissue, the genital, the lymphoid. And those are the four tissue groups that contribute to development of the face. So I mentioned neural specifically because the neural gets it going. The neural gets the growth going. So when the neural tissue expands, so it plays a role in the initial development of the skull base, and the calvaria to really encase the brain and form its platform. So this Kamman's growth curve was already released in the 1930s. So we're close to getting to 100 years. It's amazing of understanding what is growth. So craniofacial growth is not simply matched with one tissue type. So we've got the part neural, the brain, the central nervous system, and the peripheral nervous system, and it's part somatic. So part body tissue, skeletal, muscular. And the craniofacial growth forms or falls somewhere in between. So we've got this development of the neural and general, and then we see that red line at the bottom where the general plays a role in boosting the general growth. So as we get to puberty, and we will discuss that later on where that has an influence, that also boosts the body growth. So those are kind of in sync, but the neural gets it going from the start. So we'll see around about age 7, the neural tissue have almost reached its maximal adult size. So we are sticking to the face. So you've signed up and signed in to see what are we talking about, especially growth of the face. So let's just define where the face fits. So the chondrocranium, so the desmocranium being the cranial vault, the chondrocranium, the desmocranium being the cranial vault, the chondrocranium being the cranial base, the splanchnocrinium being the jaws of the face, the maxilla and the mandible, and the dentition, and that all forms together, finally gets to the craniofacial skeleton. So these anatomical units form a functional unit, which gives us the craniofacial skeleton. So we're going to focus on the cranial base and the splanchnocrinium. So we are going to be focusing on the upper, lower jaw, and also the cranial base, because these two anatomical units form the face, form the functional unit of the face. So those two components together gives us the face. So let's talk about cranial base. So I'm back at the cranial base again. So you're thinking, oh my goodness, we're delving into the part of the brain here. But it is super important because we've just said to each other that those components all add together what we get the face in the end. So the cephalocaudal gradient of growth was already discussed in 1928 by Robbins. And the sequence of development here is quite important. So the sequence of development here is that the cranial vault first, so it encapsulates the brain, then maturation follows onto the anterior cranial base, posterior cranial base, then the maxillary length increases, then we've got upper facial height development, then it goes over into the mandible, getting length, the corpus length first, and then more development in the ramus. So the sequence of development, so the gradient starting at vault, base, posterior cranial base, maxillary length, upper facial height, mandible body, ramus at the back, and the ramus height is the least and last to mature, and this mostly matches the S-shaped curve and the somatic body pattern. So we've just discussed 2 slides ago about the different body tissues and how they play a role. So we can see the neural gets it going. The somatic, more related to, you'll see more towards the mandibular growth, and where the hormones, you know, those tissues come to play. So neural gets it going and somatic for the rest of the growth. So let's look at cranial base growth. Now, one of the orthodontic real influencers and a great colleague, Neil Kravitz, he made these wonderful sketches. We always are wondering where is the limit of the anterior cranial base and the posterior cranial base? And the anterior cranial base has different growth centers. Now, why, Paul, are these growth centers even by any means whatsoever important? Because we must look at this anterior cranial base has growth centers, and this sphenoethmoidal closes at age 6. So that is important because it matches what Scammond's growth curve said. By age 7, we've got 90% of our brain growth completed. So it corresponds matching the neural growth by age 7. So we've got this cranial base developing because we'll see that the cranial base is responsible for pushing the maxilla down. So the maxillary growth components are different components playing a role here. We've got translation, intramembranous growth, and the remodeling taking place. Now we've got the lengthening of the anterior cranial base, which is completed by age 7. So it's literally like pushed from behind, and that gives us the horizontal growth, the forward growth. And this forward growth also gives the space for filling in the dental arches towards the back. So it gives us the increase in the dental arches too. And then also the spheno-occipital synchondrosis and the nasal septal cartilage contributes to the anterior inferior growth of the maxilla. And the eyeball growth as well pushes vertical. And of course, the tooth eruption itself, which gives us intramembranous adding of bone. And this gives us the greatest vertical component of growth. And then on the maxilla, we've also got periosteal activity playing a role. So we've got intramembranous growth at the sutures, giving the responsive growth. So that's the circummaxillary and intermaxillary sutures, and it's resorptive in other areas. So what about this is important? The most important thing is that just listen to how early these things are taking place. So by age 6, that sphenoethmoidal synchondrosis is closed. The spheno-occipital contributes, it also pushes down. That's going to close only at puberty. But we've got this pushing down of the maxilla downwards and forwards, and this is taking place early. So calvaria, cranial base development, maxilla coming down and forward early. So you can hear the maxilla coming down forward early. When we have somebody with the maxilla lagging behind, we need to grab it early. Earlier is important. So we've got this beautiful sketch from Enlow and Hans on the essentials of facial growth. And this just describes that at the base, we can see here that the maxilla is being pushed forward and down to an extent. So that was the only thing that was lacking in the sketch, was that it is being translated. So it's being pushed down. It's being added, periosteal activity at the back, intramembranous growth. Remember, so the maxilla is growing towards the back, space for the dental arches, and there's more resorption happening in front, but also is pushed down. So if ever you want to give Enlow and Hans a shout, they must just add the down arrow to the sketch. The maxilla is also growing down. That's my opinion. So the maxillary growth is in both the anterior, posterior, and a vertical component. So the overall growth is downward and forward, and it is translated as a whole by the cranial base, the nasal septum, and the soft tissue capsule itself. And that is a lovely contentious issue about how much does this soft tissue capsule contribute to it. So we know if we create the ideal environment in the face, is this maxilla going to respond beautifully? Maybe the theories of Moss might ring a bell with your undergrad studies. So yeah, that soft tissue capsule playing a role in the overall environment of where this maxilla is growing into. The sutures are responding with growth. In the anterior, we've got the surface resorption of the maxilla. Interestingly, the nasal capsule ossifies by age 7, and the nasal septum gives significant vertical growth from age 7 still. So the nasal septum contributes still. Interestingly, by age 4.5 years already, 80% of the palatal length is reached and 70% of the anterior facial heights already. So that's by age 4.5, 70% of the adult size already completed. But wait, Paul, you've been only talking about this 2D way of this maxilla growing downwards and forward. Now, what's happening in the third dimension? What's happening in the transverse? So yes, we've only been looking at it in 2D. Now we have to add width. So the mid-face width is associated with the development of the eyes at birth. So eyes are big at birth, so the face is much wider than what is longer at birth. And 2 to 3 years after birth, the width increase is due to increase in brain size, and which are the sutures that are responding here. So that's the 2 halves of the frontal bone. So it's the metopic suture, 2 halves of the nasal bone, the internasal suture, the 2 halves of the maxilla, the intermaxillary suture, and the 2 palatine bones as well, the mid-palatine suture, the maxillary process, and the palatine bones are all ready to respond to width change. But interestingly, from here on, the transverse growth is the least. More is coming anterior posteriorly later, and more is coming vertically, even more. So the growth closes first transverse, then anterior posterior, then vertical. So the average transverse growth, more than 50% is done by age 6, and only 4.8 millimeter additional transverse growth from 6 years to adulthood. So you can see it's not much. And the total average growth, transverse growth, from 4 years to adulthood is only 9.5 millimeters in total. So 6.7 millimeter is by mid-palatal suture growth, and the rest is added on the sides by apposition. So you can see from age 2 to 3, 4 years onwards, that we don't have massive transverse growth left. A lot of it is completed earlier. Now, why do I mention this importantly? Well, so when we start at infancy, we know that the palatal shells have come together like a nice zipper. I always imagine it like a nice zipper. By the early mixed dentition, the mid-palatine shells are starting now to interdigitate. And by early teens, it is quite, those shells are quite complex joined. So we know that in order to get skeletal expansion of that suture starts to be more and more difficult. So when to act. So I said our topic will be on when to act and utilize this growth. So transverse expansion was actually a study was done by Batsetti in 2001. And he mentioned that for the most beneficial and stable results, the effects are better in early patients, so before the pubertal peak, versus when they were treated later. And they did this from PA-CEPH. So a more modern way of researching this will, of course, be with CBCT, but the measurements were taken in the transverse dimension. Him and his group found that there was significant increase in the intermolar width in both groups. So the ones that were treated early and treated later, but they found that the early group had more skeletal effects. And thus more skeletal effects before the pubertal peak and more dentoalveolar effects after peak. So another very interesting phenomena that is associated with expansion. I hope you kind of see where I'm coming from. So we are describing the maxillary growth and the history behind it, or the background, maybe the introduction behind it. As we see it, it's coming from the vault base, maxilla down forward, and width is completed quite early. So we want to think expansion maybe more effectively before the pubertal peak. So another interesting phenomenon is what McNamara studied. McNamara is one of our real orthodontic pioneer researchers. He said that if you get expansion in patients with a cusp-to-cusp or a class 2 molar relationship, and you do expansion, or there's a width issue, you've got a narrowed maxilla, and you do your expansion, then often, not always, there's a positive improvement of 1.8 millimeters in class 2 patients and 1.4 millimeter in the cusp-to-cusp group, and about 1 millimeter of improvement happened in the class 1 group. There was no significant skeletal changes compared to the controls. So please don't get confused. This was now looking at it sagittally. While we're going transverse wider, there was a sagittal improvement of the mandible. So we can expect in early mixed dentition, often a significant improvement in sagittal-occlusal relation. Now my orthodontic colleagues will immediately very quickly respond by saying, but we're definitely not going to expand everybody for the sagittal correction, definitely not. But the concept, or if we look at the growth and we can enhance, or that's also not even the right word, if we can get a good environment for growth, then maybe more ideal type of situations can occur. So I want to give you an example case, enough theory talk. So we're looking now at some simple expansion appliances. So if we get a patient like this, first thing you're going to ask me, goodness, Paul, this lady, this little girl, she's only, let's go back, sorry. She's only 6 years and 8 months. What is she doing in your office this early? Why is she being referred? So I totally agree with you, but I just want you to look at the frontal view here and look at the angulation of these posterior teeth, see that they're quite constricted lingually. Sorry, let's go back to this one. They're quite constricted lingually. And we note that there's definitely a situation of space shortage in the lower, but none of that are the reason why we're doing the expansion here. We actually go back and we say, okay, what does the theory say? So the theory says that an ideal intermolar width is between 35 and 37 millimeters. And this young patient is at 33.25 millimeters. Now, let's just motivate why I'm doing anything for this patient. So even though she's chronologically 6 years and 8 months, she's dentally much advanced. I hope you can see that. These upper lateral incisors, let's just go back to our profit chronology of tooth development permanent dentition table. And we see here that the maxillary lateral incisors should only erupt by 8.25 years. So we definitely have got a patient with quite an advanced dental development. So with simple expansion appliance, a simple expansion appliance meaning a Hawley with a mid-palatal screw, a Hawley appliance, I personally like adding 2 midline screws, one in the anterior as well. And the reason for that is I have found that I often get too much expansion in the posterior and almost develop a posterior crossbite and still not have quite the effect in the anterior. Often it's like it gets displaced a little bit or something. I just found that from a practical perspective, just a side tip, it's often nice to add an additional expansion screw in the anterior. So our patient, here she is. You can see the convex profile, definitely close to the mandible is retrognathic. And yeah, we can see that something can be done. So we have a 6-month period of placing an expander, an expansion appliance. And we also expanded in the lower just a little bit, just for arch coordination. And we have found that there was quite an improvement in the sagittal as well. So do I want to encourage everybody to now start doing expansion because we get improvement in the sagittal as well? Definitely not. There was an indication for expansion here, and we had definitely noticed a constriction in the upper. We measured the intermolar width. It was a good motivation to do expansion here, and we had the positive effect of the improvement in the sagittal as well. So I want to just mention with the expansion appliances that in these young patients, whenever we are doing expansion, whenever we are doing any type of treatment, I always imagine it like being at a patient ATM. We do withdrawal from this patient's compliance over their orthodontic lifespan, if you want to call it that. So every time you do an intervention, we deduct from this patient's compliance. They will definitely share with their friends or family around the bride that they had braces for 15 years or something crazy. So when we step in, especially in the mixed dentition, early mixed dentition, keep it as simple as possible. Keep it as simple as possible. So in the first case, you could have asked me, okay, Paul, you know, the intermolar width, you know, it's the indication for expansion is not so clear. So let's go to the next case. So this young boy, he had the blocked out 1-2, the blocked out lateral, and he also had this cusp-to-cusp relation on the side and the distal step molar relation here. So I'm just going to move my little screens here so that I can just see my slide fully. So, and on the left side, we can see here that also the distal step and the space shortage in the upper, of course, that blocked out lateral is blocked out because of the space. And you can tell me something about the active frenum. I will totally agree with you. And we will look in the mandible, and we will see that there's a carious tooth 8-5 there is problematic. So Paul, you're saying, okay, let's keep it simple. So let's keep it simple. We're going to now, for this young guy, just do something simple. So what I did was I placed a quad helix appliance in the upper to create space. A quad helix appliance is a nice appliance to control both anterior and posterior expansion. I must say sometimes I'm not so super keen on using it. Depends on how compliant your patient is and how well they're going to care for it. Because if you like emergencies, sometimes quad helices can be really troublesome. They can distort, and even if the patient is not careful. But there are no fixed rules. So if we remember anything tonight, that there are no fixed rules, exact like how you should approach it or how it should be done or anything like that. I think if we just keep our patient profile, their best interest at heart, and when we do our appliances and really get in there, that it be effective. Just get it be effective. I like the RPE screw lately more. It's more rigid, a little bit more tough to clean for the patient, but that's totally personal preference. Let's get back to the case. So Space was created in the upper, and a partial fixed appliance was used to bring the 1-2 buccally. Of course, you can see there that the root is still beautifully palately. So, but I didn't want to be hang on that 1-2 lateral too long, because of course the canine is coming down, so I just have to be careful. But I want you to note how the sagittal relation improved as well. So yes, the anterior crossbite was corrected, the space was closed, the midline diastema was closed, and we extracted the caries 8.5, placed the lingual arch to make use of the lower leeway space. We're going to talk space later, the lower leeway space. And yeah, there was quite an improvement in the sagittal as well. So I just want you to note that we've got this improvement in the sagittal too. Now with Murphy, and I hope you notice it, that once I extracted that 8.5 and kept the space beautifully, this beautiful 4.5 did not come out, yes, like I wanted it to. It was quite rotated. So yeah, now in the second phase of treatment, of course, we will have to address that 90-degree rotated 4.5. So let me just move away these. So do all distal step narrow arches need expansion? Definitely not. Determine it case specific. So if there's anything that well, that is not possible to really teach or share, it's just like these steps are done for this type of case. It is quite individual and specific on what needs to be done. So obvious things like a posterior crossbite with a functional shift, certainly yes, and we need to expand there. And if you're going to ask me in the young children, something that's really recent on everybody's discussion in the dental community are the myofunctional appliances. So are they useful at expansion? So I'm kind of neutral about it, because in some cases, I'm sure they can be indicated, but any appliance where is time deducted from the overall patient compliance. So I just included here the effectiveness of the prefabricated myofunctional, let me just go back. The effectiveness of those myofunctional appliances, they did a systematic review on its effectiveness, and essentially what was said that we have an issue of patients really engaging into wearing it, and they mentioned that we don't have much effect on the upper incisors, more the lower incisors proclining, and there isn't good evidence suggesting that there's really a clinically significant effect. The one positive was that they said it was cost effective or it was cheap to make, but yeah, it's just that now we're giving the patient an appliance and we're not really confident. We're not really sure whether it's working. And is that an ideal type of scenario? I would suggest maybe, getting in there with proven effective things and making sure it's short and effective. So the patient compliance ATMs make those withdrawals wisely. Okay. So I see I am talking way too much. It's already 43 minutes. So let's get into, okay, maxillary retrognathia. So now we've discussed that it is beneficial in certain circumstances where there's a posterior crossbite with a functional shift, certainly, where there's a significant space shortage, where we've got this constriction in the upper, and you can see it really has an effect sagittally. It is positive for us to expand in those circumstances. So now we get to why we need to get to our maxillary retrognathic patients early. So this young girl came to me, she's 7 years, 1 month, and she's got a beautiful example of a full class 3 anterior crossbite, mesial step at the back, significantly maxillary retrognathic bite. So she could not posture into an edge-to-edge relation, and we need to now look at why we are going to do anything for her. So she's very young, she's 7 only. Why is she at my office at this time? So we need to step in, because the indications for early growth modification in class 3 patients are that we want to prevent the irreversible changes, especially the wear on the mandibular incisors, the compensation of the mandibular incisors, and the thinning of that labial alveolar plate. To improve the skeletal discrepancy, we want to create a favorable environment for growth, improve the occlusal function, simplify later comprehensive treatment, and improve the facial aesthetics. So, what am I going to do for her? We are going to promote the growth that is occurring in our young patients. So we need to stimulate whatever the cranial base is giving us, whatever the nasal septum is giving us, pushing down on that maxilla. We need to get that stimulation early when all those elements are happening, when the cranial base is still pushing down, when this maxilla wants to come down and forward, we need to do that. So how do we do that? We gave her a reverse pull headgear, exactly like the Prophet sketch here, where we've made a full occlusal bite guard that was a full occlusal acrylic plane that was bonded, pulled down and forward. So we immediately acted on her. So what are the indications for class 3 growth modification? Is where the patient generally has good facial aesthetics, where there's a mild skeletal discrepancy, no familial mandibular prognatism, an anterior-posterior functional shift, convergent facial type. The horizontal growers, those are favorable to do, and where we've got symmetric condylar growth. And of course, the patient still has to be grown. And we need good cooperation with the use of this appliance. Now, Paul, you will ask me, Paul, but that patient was quite significant skeletal discrepancy. I totally agree with you. But if we go back to our diagnosis and why it's important, we can see that she also had a vertical issue. So not only anterior posterior, vertical as well. So if we can get her down, we can open the bite and we can get mandibular rotation, we can get her open. So we can quite have a positive effect on that mandibular position as well, because she's very horizontal. So she's very horizontal. So the diagnosis in that case is very important. Now, another young boy comes to me. This patient can bring the incisors edge to edge, so he's much more favorable for a class 3 growth modification patient. But we see that he had some serious dental loss in the upper arch. Now, I immediately sulk and think oh my goodness, how are we going to tackle this? Because we have these space loss issues in the upper, and if we're going to now put a expansion appliance on those molars and bring them forward, we're getting them to mesialize more. So we made a plan by giving him these growth or titanium plates for growth modification. So these titanium plates were added in the maxilla. And of course, your remark might be that, goodness, this is ambitious. And it certainly was. But I want to get to the principle of why it was done. So these plates are attached to the maxilla, and we pull downwards and forwards to get this maxilla to grow. And we use partial fixed appliances to create the space issue, because now we could do skeletal correction while we're doing the dental correction as well. So in some cases, you now have to consider both the dental components and the skeletal, because now Paul said was, now let's get in there. By age 7, you should have started with this class 3 patients. Great. I've got this. We're going to do some growth modification. Look at where those molars are. So we had to do a combination of skeletal correction and dental correction at the same time. And that's where the situation gets a little bit more tricky. So we got beautiful maxillary growth. We were able to bring that maxilla forward quite a bit. You can see there that the growth remained quite horizontal. The maxillary vertebrae came forward. Yes, if you want to critique me, there was definitely some maxillary incisor proclination. So, but the principle is we had to act early. We want to really make most of what's happening to that maxillary growth as well. So just in summary, class 3 is what to do when. The suggested treatment is that we really start by age 10. So well, sovereign prophet really confirmed by age 10. We should have acted there. True skeletal changes decline beyond age 8, and overall clinical success really goes after age 10 to 11. So please, if there's anything that we remember, is those class 3, especially if there's a maxillary component to it. and not a frank mandibular excess like it's familial, everybody, uncles, grandfather, everybody has it, then we should get to those clause 3s early. That would be really great. So now let's get to our mandibular growth. Now, lovely argument or dispute, or I don't know, it's not even nice, the growth of the mandible. Now, if anybody has the final answer on that, they will definitely win the Nobel Prize. So mandibular growth, of course, different components. Most of the growth happens at the condyle, surface apposition at the front of the ramus growth, and added addition at the distal end of it, or the posterior, but primarily condylar growth away from the cranial base, and secondary, it's displaced by the middle cranial base. So if you remember, the spheno-occipital synchondrosis closes between 12 and 15. So that is important to remember, because now the middle cranial base growth pushes the mandible down as well, and we've got till later to fix that. We've got now till puberty to fix that. So the mandibular growth, the condylar growth is the big contributor there. So it is proved to follow the somatic and other craniofacial structures. It decelerates to a prepubertal minimum and then accelerates to a maximum adolescent velocity. So we really have that a real good petrol on it, acceleration in growth during puberty. For males, it's interesting to know that that peak of growth is reached at 14.3 years. So most of them will be South African school grade 9, and where that condylar growth is up to 3.1 millimeters per year. Now that is a lot. The females reach their peak earlier by 12.2 years. So they're usually around about grade 6, grade 5, grade 6, 2.3 millimeters per year. And McNamara and Francia have been using growth modification appliances at puberty and have proven their effectiveness at this time for years. So if there's anything to remember here, it's just that we've got this mandible and it's waiting to respond maximally during pubertal years. So why is this important? It is just that whenever we treat our patients, we really want to step in, have the most effect, and step out. So often we do see people in fixed appliances maybe too long, but we really want to get in there when we've got the most efficient growth happening. So do we actually grow the mandible? So the answer maybe is a little bit more simple. We're definitely not growing it more than what it would have. So we're just maximizing its genetic potential. And if I may add my own conclusion a little bit, I do see postural improvement in patients quite a bit. I definitely see them, that last bit where you have good interdigitation and they have got a good class 2 improvement. There was definitely growth, but also a positional, maybe maximal effectiveness, what you got with your class 2 correction. So we are not growing the mandible. Now I've got this patient. She is quite young. She's a 9-year-old, 9-month female. She's got significant mandibular retrognathia. She's got a 14 millimeter overjet. The maxillary incisors are proclined on the CEPH, but not that clinically severe. She's got a mandibular deficiency and a large nasolabial angle. So you're asking me, please, I haven't touched her with the headgear or anything. She is like this. Her nasolabial angle, her upper lip is already a little bit flat. And I'm showing you this case because the only 2 indications for earlier treatment of class 2 patients are those very proclined central and maxillary central incisors, because they're going to get trauma. And if there's any social, if their children are being bullied or anything, those are the 2 real indications for addressing a class 2 malocclusion early. So I'm showing you this case now because I don't want us to box things. Because now I've mentioned that, okay, Paul, the mandible is now only responding more at puberty, but why are you treating this girl now earlier is clinically she needs treatment. So if we are unsure, if rather act or refer this patient earlier so that we can address this issue, and not because, okay, now we've made little rule books saying that we only refer the patient or we only treat this patient at that time. So that is why we are discussing this case. So is it too early? Yes, you can tell me, certainly. But we also consider the eruption stage of this patient. So she was going to exfoliate her primary molar soon. Time with near exfoliation of those lower E's. So if you've got a female patient and those lower E's are about to exfoliate, sweet spot, good time to treat. And we got this patient with a very good stimulation of the maximal mandibular growth that was already there. So I treated her with a twin block appliance. When we finished the twin block appliance treatment, she was just going to exfoliate that E. And when we stopped with the twin block appliance, I immediately went over into fixed appliances because retaining this correction is most difficult. So now I've got this excellent improvement in my patient's overall profile. So we really did get quite a bit of mandibular maximal potential. And did we dish this face? I hope you agree with me. Certainly not. So we really got excellent growth or the maximal potential of the environment of the growth of that mandible. So was it in any way some kind of magic trick or anything? Absolutely not. Yes, we had retroclination of the maxillary incisors too. Of course, they had to meet. But yeah, the combination of the effects really played out well. Now, my concern is, and if we go back to the CEPH, we unfortunately don't have time to go back to it, but you will see that cervical vertebrae indicated that she was actually a little bit treated a little bit before the pubertal peak. And so I monitored her and I watched her and I made sure that I get my patient on social media and check that what is happening with this young lady. And she was still stable. She went through the pubertal spurt, growth spurt, but that fizzy drink is definitely not our influence or my influence in maybe my patient education was lacking there on what she is supposed to be eating. So if we remember anything, is that for the maxilla, zoom it earlier. We really need that sooner acting on the maxilla. If you see a class 3 early, if you see the constriction in the upper arch, then we must act sooner. But the mandible only catches up a little bit later during puberty. So it won't be a mistake to act on the class 2 later, but obviously for those severe patients or we don't have to wait it out. So that's basically all that I want to get to, is that there's no rule book like, okay, puberty, those E's must come to exfoliation first. No, there's of course your discretion on when to act. It's just that when we get to the growth, and that's a cephalocaudal gradient of growth, to really understand where it's coming from and why we need to act in the maxilla earlier, and the width, anterior, posterior, and then getting to the mandible later. So that's basically just a summary of what I've just said. So diagnosing is everything. It really is. So this orthodontic triage is from the Prophet textbook, but for myself, even when I look at a patient, it's still the best way to assess the complexity of the case. So if we get to the full facial proportions, just looking at our patient from the front, we're diagnosing, we've got this patient in front of us. Is there any syndromic features or major asymmetries? And if there's not, great, we continue to step 2. But if there is, I would definitely not be thinking of maybe tackling that myself. So if I was in general practice, that would really constitute maybe something more specialized. And then we assess our patient in profile view, because of course we meet our patients, so we check them from the front first, then we get them in profile view. Class 3s early. Class 2s, if there was significant protrusion, and it's in the maxilla, and the incisors are very proclined. Of course, a simple appliance to retrocline those incisors, get them out of the way, get them out of trouble by all means, but just make sure to check the vertical clearance, just make sure to check your overbite if you have space to do that. And of course, if there is a clause 2 developing because of a habit, by all means, stop the habit, a tongue gate, anything to get the tongue out of there, or the thumb, digit sucking, anything. So we really want to encourage you to act on those type of things, step in, stop those habits. But those myofunctional plans, like I mentioned, not for true skeletal change. That would be ambitious. And the girls earlier, remember the girls, we said that peak growth by 12.2, so that's definitely grade 5, 6, and the boys later, grade 7, 8. So now we get to the dentition. So we've looked at our patient from the front, from the side, we get to the dentition now. In Afrikaans, we'll say you must count the teeth. You must die tanden tel. So you're literally just going to take your pen and you're going to start and count your teeth. You look at the dental development, whether there's missing or supernumerary teeth, whether there's ankylosed teeth, and whether there's impacted teeth. Now, I encourage everybody to please, age 9, 10, feel for those canines, feel for those maxillary canines especially, feel them, are they positioned buccally, check your pans, age 9, 10, those C's, is there resorption on the C's? Definitely very important. And of course, you would have noticed the ectopic 6s because it's not coming into occlusion. So those brass wire tricks, I've done a few myself. They're definitely not that simple to do, but they're very effective. Is unlock that E, or sometimes the E has to be extracted, but that's us looking at our patients from a diagnostic perspective, starting on the outside, frontal, lateral, now get to the teeth only, because we love just going, we need to see what's happening to the dentition. And then we get to our space assessment. So first we check for those more major anomalies. Then we get over to space. Now we can see the space is really little here. What is little space? What is too little space? Have we lost the ease early? Was there a loss of leeway space? So are we going to maintain or regain and then maintain? If you're in the lower arch, something I can just mention, if you're going to do space maintenance, watch the 7s. Often the 7s can impact if you have the lower lingual arch. So just check how you're going to manage that space. Then, very importantly, after checking the individual teeth and now the space, we also check displacement. And we want to encourage, now we're looking at function, if you've got a posterior constriction with a functional shift, then that has to be addressed early. So we know that growth is completed in the width first, the mid-palatal suture is closed after puberty, so please refer those or address the transverse issue earlier. Major overbite, overjet, rather refer, especially the deep bites. Those can be an absolute nightmare if you have to start closing spaces in those. So watch the displacements and the space coming up there again. Oh, I placed it there so that I can talk to you about the arch perimeter changes. So when we go and we look at the growth related to what's happening to the arch perimeter, so we will see our patient with very little space in the early mixed dentition. So we'll already see an issue with space, and we'll be worried, okay, don't worry, mom, it's going to grow. Just note that in the maxilla, from mixed dentition to the permanent dentition, we're actually just losing perimeter. Remember the loss of the leeway space, but because the canines erupt in a wider circumference, we only get 2 millimeters extra. So if we do see a space shortage in the mixed dentition and we're going over to permanent, if the extra 2 or approximately 2 is not going to make it, we know there's going to be a future space issue. And in the mandible, let's look at what's happening from the intercanine width from the mixed dentition to the permanent, only 0.7 millimeters additional space. So we can see if there's crowding in the mandibular anterior already and it's significant, of course, it will have to be addressed later. So mom or dad will often ask, like, will this child need braces? So you can tell them in the mixed dentition, mandible, only 1 millimeter extra intercanine width will be gained. And actually in adulthood, we can see that with aging, mesial shift of that lower dentition is going to take up some space as well. So we have 1.2 millimeter space loss. So I just put these graphs in to show you that most people will have a tendency to have space issues in the mandible. So especially the females. So the tendency to get perfection in the lower dentition without orthodontic treatment is not normal. So in the class 1 skeletal pattern, we can wait till permanent dentition, no problem, to address the space issue. But with the class 2 is closer to puberty, and the class 3s, if there's a space issue associated, we will have to act earlier as well. So this case I just placed here to show you that now this patient comes to you and, okay, Paul has just spoken about space. Okay, that's quite normal over there. That's not such a big issue. We know the intercanine is not going to change much. Okay, he's a class 2. Maybe I can do something with advancing the mandible here. Dentally and the upper arch, the 1/6 has shifted mesially. But of all the issues, all I can definitely say is, oh my goodness, I can see the over-eruption of the maxillary anteriors, and he is definitely a gummy smile. We have to intrude these guys. So again, we can't look at the different aspects individually. We can't just say, okay, space-wise, kind of normal in the mandible. Okay, the upper, we can address this. Yes, we are waiting for the canines. No, this patient was actually very effectively treated because I could start earlier with intrusion mechanics in the upper. So if you are unsure, assess your patient, the whole picture, get as much as possible, and let's act in an ideal time. So he's 12 years, 3 months. So it's ideal timing, preparing him dentally so that we can do growth modification treatment. Now let's just finish with this interesting case. I just want to talk about this patient here. When you look at her and we do a quick facial assessment, so from the front, yes, I can see the chin deviating, Paul. I can see on smiling as well, something's not great. Okay, the 45-degree assessment, I can definitely see something with the occlusal plane, but not too much. And of course, profile view, significant convex profile. Okay. Now, she goes to her dentist in 2015 with the main complaint of pain in the upper left area. But what is not noticed, and I'm not saying that I would have definitely noticed it myself, is that you can see that there's some canting here in the occlusal plane, but you don't know exactly what it is. It's late afternoon, you're checking the pan, you're seeing, carious, 6'5", pulpotomy, we need to go. Now, note here that we have got a fracture on the upper left. And the condyle is actually lying right there. So now we address the dental issues, and 2019, patient comes. Now, doctor, I can only chew my food on the left side and not even well. There you can see that 3/7 is completely lingually. I'm lacking in cleaning because my teeth were just basically uncomfortable. So you can see here what happened is we had ankylosis of the TMJ on the left. So there's a facial asymmetry. The mandibular rim is shortened on the left side. She had limited mouth opening. She had class 1 buccal occlusion on the left, but she was completely class 2 on the right. Open bite, poor oral hygiene. Okay, so you can see that this case went south when, if we did something about the growth and we assessed that condylar fraction occurred, we could have, with a simple hybrid functional appliance, managed to open that up a little bit and get the translation. So she had the rotation to get the translation and get regrowth of that condyle. So I mentioned this case because the management again is the class 2 overshadowed your decision making. So you were like, okay, dental, okay, I'll address dentally, and then my patient is fine, she doesn't have pain, and I'll send her for the class 2 when it comes to the class 2. So no boxing of our diagnosis. So we'll look at our patient from the front, we can see the asymmetry, but it's not that super clear, the chin deviation. So it's not like you could see it from the start. But now what we needed to do is we needed to assess that on our panoramic radiograph, that there was a historical fracture on that side. So yeah, simple hybrid appliance would have helped to fix that. The limited translation, we had the minimal vertical ramus growth, condylar growth couldn't take place, ankylose of the TMJ. So all I'm asking is that we assess the full radiograph when diagnosing our patients, and always have the best interest of your patient at heart. So if you look at your patient holistically, is the right word, everything from the frontal view, the lateral view, the space, all of those aspects together gives you a picture of your patient. But we must remember that addressing the class 3s, we have to treat earlier, because the growth from the maxilla comes down earlier and the mandible responds better during puberty. But sometimes you have to step in earlier. Sometimes there's trauma. Sometimes there's going to be trauma with a clear, massive overjet. So I hope I sketched a little bit of a picture on why it's not so boom, straightforward. Where growth comes into play, why diagnosis is important. And yeah, I hope it wasn't too much information overload, and you got something from it. And yeah, maybe one or two more practical aspects can be discussed in future and stuff like that. But yeah, that's just some information regarding the growth of our patients, and when we should act, and how we should act, and how we should look at them. So yeah, that is me.
Okay, thank you, Paul, for that very insightful lecture of yours, and those excellent case presentations that you showed us. I'm sure it sparked a lot of questions and interest among our viewers. I see we do have some questions, and we've got time for some. So I'll start with the first one from an anonymous attendee. He asked, or she asked, that can adult patients with sleep apnea be helped by increasing their airway space through orthodontic treatment? So this pertains mostly to adults, which, you know, we're actually discussing a growth lecture, but I think we may just touch on the importance of advancing the mandible to increase that airway space. I don't know if you want to answer that.
So the airway regarding growth appliances is quite a little bit controversial regarding how the research was done in the past. So it's always a two-dimensional image. First, it was cephalometric radiographs. If you had the patient breathing well in this one radiograph, and you would take the next, then they would have swallowed, and then the airway would have been closed. And also the CBCT studies were really difficult to do. So what I got from those is that if you think of it practically, yes, it could make sense. I mean, for sleep apnea, bimaxillary advancement, if you advance the maxilla and the mandible to really open the airway, by all means, there must be a practical widening of the airway, but with growth appliances. So if we talk about our growth patients, because now in our adult patients, the structures are more stable. So you have like non-growing patient, you're going to move these two elements, you're going to move them forward, and you're going to release pressure on the airway by all means. But with growth appliances, there is definitely no clear indication that, yes, we are getting the sleep apnea corrected. We are making sure that our patients are breathing. So we are never to promise our patients that we can solve their sleep apnea by giving them a growth appliance. We get improvement in the posture. Yes, if you have better breathing, by all means, fantastic. But I mean, there is so many factors playing a role, and we can certainly not guarantee our patients that we are improving their airway.
Thank you, Paul. The second question from the same attendee is the following. Do you think the use of headgear can contribute to the development of sleep apnea later?
So I'm not a headgear practitioner, but I know that if you are really an excellent headgear wearer, and Johan, you must correct me on this, and if you get 2 millimeters of molar distalization and you really get your patient into this fantastic class 1 occlusion, there is, for me, practically no single way that you can retract enough to seal off anybody's airway. So if you have got severely proclined incisors and you are using your headgear for good anchorage, because you need to get those incisors back with the mandible, and since we have improved by judiciously really applying our retraction to such an extent that we are looking at our faces and we're not flattening anybody's profile, we're really focusing on that, and we get the mandible to respond positively as well. There, I must say, I will give you a good prize if you can retract those maxillary teeth so much that you can close off the airway. Practically, to me, I think it's impossible.
I agree with you there. I don't think there's any scientific evidence to state anything close to that. Let's move on to the next question. Another question from one of the viewers are the growth dimensions mentioned for a specific racial group or a more generalized dimension or figures, which perhaps covers all racial groupings?
Well, I love the intricacies of the different racial aspects about profile. My study was on bimaxillary protrusion, and yes, so we know our Asian patients are more prone to class 3s and more so genetically maybe, and maybe our African patients with the bimaxillary protrusion more vertical, often maybe slightly more class 2, but I can't say that as well because you get, it can be a hidden class 3. So sometimes if you can close that, you'll see the rotation back is almost a masked class 3. So I think there's no definite box per se for the different races, except for the Asian patients that are more prone to class 3s. And then you must look at those criteria for when you will do growth modification for your class 3 patient. If it is significant, it's mandibular excess, it's out there, there's no way you're going to fix it with a reverse spool headgear trying to stimulate that maxilla. So that's where diagnosis is so important. I think maybe what I didn't mention enough is that if you have maxillary retrognathia, if you have the maxilla not reaching its full potential, that's when we will go for it. But if you've got frank mandibular excess, there's no sense in chasing the mandible, no matter what race you are. So I think, yes, for Caucasian patients, often more class 2s, class 2 division 2, especially the females. Maybe that's somewhat a general comment from my side, but irrespective of race, case specific, diagnosis specific, and get to your answer. Look at the family history, and yeah, there's definitely no box I will put anybody in.
Yeah, well answered. Thanks, Paul. I think we've got time for 2 more questions. The next one asks, do you see patients arriving too late at your practice, particularly class 3s? Is it something you find these days, and at what age should an early assessment ideally be conducted?
Yeah, so in the past, even for myself, I often, just to quickly get rid of the question, mom would be like, okay, isn't booty or sissy time now for them to have the brace? I would say, no, let's wait for the permanent teeth to all come through, because they've heard from their friends, if you start too early, it's a problem. So maybe a entrenched mindset has been like, we wait for more teeth to exfoliate, we wait for the mixed dentition to be completed. So the class 3s that can be managed well with orthodontic treatment. So subtly, maybe an edge to edge, or those ones that could have really benefited from maxillary advancement or stimulation. Yes, I do think sometimes they do come a bit late. That is, when they ask me about a topic, I would say that maybe we should just all talk to each other a bit more about that, is that I find that they do come too late a little bit. So again, not the same picture for everybody. So when you have a class 3 tendency patient, the assessment won't hurt anybody. So it would be great to just do an assessment, see where the problem is, diagnose properly and give the best advice, rather than saying, wait, and the profile is really flat in the upper, we could have done something, and now the patient, if they really want ideal results, have to go for surgeries, because in the end, we're trying to get our patient to not really go through that process, although it's got its fantastic benefits, but to really improve their profile. So I would say that we should not just give like a standard answer, like when all the teeth are out, then go. So maybe that's one thing. And you asked me about, what was the second question?
At what age? Is there an ideal chronological age to refer a patient?
The American Association of Orthodontics advises that actually patients should have their first orthodontic assessment by age 7. Now I can hear the bells ringing, going, no, we just want to see the patients early. But actually, the obvious things like a missing central incisor. So there's pathology in the front, the incisor is not coming down, that's dead obvious. So that those patients do come through. The ones with the habits, significant habits and things like that. So again, case specific, an early assessment of a patient that has a big asymmetry in development of the dentition. So we'll see something's erupting on this side, not on this. So we've got our eyes wide open all the time. Then my answer would be, there is no age limit down or up where we can look at the orthodontic need of the patient. So but I would advise or encourage act earlier rather than later.
Okay, excellent. Paul, there's a new question someone just posted about rapid maxillary expansion. The question is, whether rapid maxillary expansion above the age of 15 is contraindicated in a patient with a bilateral crossbite who wants to undergo orthodontic treatment. So is that contraindicated? Is it too late, 15 years? That is the question.
Yeah, so I would still, if you ask me, I would still attempt rapid palatal expansion, of course, under supervision. So by 15, definitely the maxillary halves have interdigitated well. So it is starting to be borderline, in my opinion. But if you have a significant constriction, you monitor your patient well, you check whether they have pain or extrusion rather than properly seeing the midline diastema developing in the two halves, then of course you know that from a practical perspective that maxilla is not going to open up. But age 15, I would still attempt, but keep a good eye on your patient. So monitor that patient well, get them in after a few turns, make sure what you're doing has a positive response. So I would say it's possible.
Yes, I agree. And if I may add to that, I think it also has to do with the skeletal maturity of the individual, which could be investigated. And then new techniques have come to the fore, such as SARPE, which is skeletally anchored rapid maxillary expansion, where they use implant-based prosthesis, or not prosthesis, appliances to actually conduct the expansion, and successfully in older patients. So it will depend. And I agree with you there, it's definitely a possibility.
Yeah, that is Mariana Evans is a name there to really read up on. She's a real expert on the skeletally anchored MSE, I think they call it, maxillary skeletal expansion. We have the components placed on the bone to get the maxilla to open, and they show beautiful results where you have orthopedic or skeletal expansion and not getting the molars to tip. So the experts on that, they really watch those molars because it's a proud thing to really get good expansion without those molars flaring out. So yeah, no, definitely, totally agree. And yeah, just to mention the skeletal maturity, of course, we know the gold standard being the hand wrist, so we can check whether the growth plates are closed, and of course the cervical vertebrae. I know the British Orthodontic Society is leaning more to first assessing our patients' skeletal maturity through that, and then taking a hand wrist. But yeah, of course, skeletal maturity.
Thank you very much. I think that's all the time we have for questions tonight. And I'm going to hand back to Vishal. Dr. Bika, thank you so much. Thank you, Paul.
Thank you so much, ladies and gentlemen. I think that was a very informative session. I think thank you to Dr. Fouché for being our guest this evening. And then thank you also to Dr. van der Berg for facilitating the session. Ladies and gentlemen, I think just if you can just answer the evaluation, Paul, that would be highly appreciated. And I think maybe for some of the questions that weren't answered, maybe Dr. Berg can get in touch with Dr. Fouché, and maybe you can post up the question association. Other questions can be answered. So ladies and gentlemen, thank you so much for joining us this evening, and stay tuned for join us later in this month for all the other sessions that we will have. Thank you. Have a good evening and good night. Thank you.